Test 1, 2. You can move those around all you want.
Sir?
You can move those around if you need to share them with people. Check, check.
Yeah. I'm a Hopkins student. Are you a Hopkins student now? I am. I'm actually in the medical school. I completely pivoted. But still interested in public health and law. Yeah, you were at Hopkins for. Oh, really? I did a story there. We can learn about it. Interesting. Okay. I think I like emailed you when I first got to Hopkins because I realized I saw your name on like a bunch of abstracts here.
Right, we already have some participants online. So hello, everybody online. We are still waiting for a couple of minutes to let people to come because it's 8:30 in the morning and it's the 4th days of the conference. So just give us a few more questions, seconds, and it's great to have you online.
Oh, yeah. Oh, yeah. It's insane. I can't follow it. I'm just like, yeah. And
Remember when like
oh, yeah. Okay. And because I get all of the hospital hours daily. Yeah. Yeah. Oh, yeah.
decided that they're.
Yeah.
It doesn't show anymore. It doesn't look like active. But we do have some participants online, so like it looks like this, and it looks like there was a woman. So I'm wondering.
Okay, are you ready? Oh, I know. Okay, fair enough. Yeah, I was at Duke for undergrad and then so here.
Before and see people training.
Yeah, so I'm working in.
John is still present.
And then we're like. Yeah. Yeah. It's very nice. Yeah.
Not the videos.
Oh, it's, oh.
So that's good.
Yes. Wait, I was able to do like 1 year at first bird. I know. So it was not. Oh, you decided log in.
It's still okay.
It's okay. Great.
It was really a little bit.
I don't see any more the presenter. Great.
Yeah.
Okay, so let's start. It's great to see that more people joined us because at 8:30 there were like 4 people in the room. We were a little bit worried there will be less participants than the presenters. So thank you very much for getting up so early and coming on the 4th day at 8:30 here in the morning. And we are looking forward also for the discussions in the second part of our presentations and our event. So our event is about WASH and healthcare facilities, and we are basically covering 2 bigger topics. So we start with the general global perspective with GMP data and with the water insecurity indicators with Rick and Josh presenting. Afterwards, we will go more into the sharing experiences of implementation of the WASH FIT, as well as the reviewing the gaps in all existing platforms and tools which are there on WASH in healthcare facilities. So just very shortly summarizing the gaps which were identified in the study. Afterwards, we will look specifically in some of the tools which we have been implementing in our experiences from Mali and Burkina Faso. And at the end of the session, we will specifically talk in more detail about the behavior change and experiences of behavior change, development of behavior change for the methodology for the healthcare facilities. So starting from global and going to very much into the detail. In the second part, we will have time for discussion. We'll have breakout sessions with some few tables and kind of catch up on your information, your ideas, your experiences. So yes, let's start with the first presentation. I would just quickly like to present everybody here who we are, our group are. So Rick Johnston from WHO, and quickly introduce yourself. Yeah, maybe.
Hi, I'm Rick Johnston. I co-lead the WHO UNICEF Joint Monitoring Program along with colleagues at UNICEF.
Then we have here Josh Miller. Josh, could you quickly introduce yourself?
Thank
Yes.
you, Rick. Josh Miller, fourth year doctoral candidate here at UNC Chapel Hill in nutrition.
Then we have Christina from Helvetas.
Good morning, everyone. My name is Christina Barstow. I'm the Director of Strategic Partnerships for Helvetas in USA. Thank you. Good morning.
Then we have Sudarshan Napun.
Hi, this is Sudarshan Napane. I'm the head of country office for programs in Nepal. Very nice to be with all of you. Thank you. Anybody else? Yeah.
And
Hi, my name is Andrea Tamas. I'm one of the co-founders of the Ranas consultancy. We work in behavior change.
And I'm Maryna Peter, and I'm from the University of Applied Sciences, Northwestern Switzerland. So giving over to Rick.
Good morning, everyone. Good morning also to those of you who are joining us online. There is simultaneous translation into Spanish and French available if you're online, so make sure to take advantage of that. I want to just briefly introduce the global indicators and some data from the GMP's most recent report on Washington healthcare facilities, which came out in 2022. We're on a 2-year cycle where we update the global database every 2 years. We were supposed to come out with the first report in 2018, but we didn't quite manage it. So now we're on a 2-year cycle, which means that in 2024, we'll have our next update. So we're getting ready for that right now. I'll mention a bit more on that at the end. But like our work in households and schools, we use service ladders to describe basic levels of service, also facilities that have some but not all of the characteristics of a basic service. We call that a limited service, and it's useful to distinguish those from facilities, healthcare facilities that really have no service at all. Because of course the interventions are going to be different if you're starting with nothing compared to if you're starting with something that doesn't quite meet all of the criteria for a basic service. We'll get into the definitions one by one later, but the key thing to note is that unlike households and schools, we have more ladders. So we have water, sanitation, and hygiene, but also given the specific context of healthcare facility, there are service ladders for healthcare waste management, as well as environmental cleaning. And for each of those service ladders, we promote and suggest use of some core questions that can be included either in routine health management information system type data collection or in facility assessments. There are 16 questions here, which would allow calculation of the 5 different service ladders. Each of the basic service levels is actually a composite indicator, so they tend to need 2 or 3, or in the case of sanitation, at least 6 questions, individual measures to get at that basic service level. This resource is available in multiple languages as well. So our 22 report had a special focus on infection prevention and control and the links between IPC and WASH. So we started the report with the hygiene section. We don't always have to start with water. And also we were very pleased that this was the first report where we had sufficient data to make a global estimate of the basic hygiene services in healthcare facilities. And that's defined as having hand hygiene facilities that are functional at points of care. And at points of care, we could be talking about water and soap, or we could be talking about alcohol-based hand rub, but also having hand washing materials at or nearby toilets. And for toilets, alcohol is not sufficient because alcohol will disinfect hands, but it won't remove organic matter. So after using the toilet, water and soap is really the way to go for hand hygiene. So we did have enough data from 3 of the SDG regions to produce regional estimates, and also at the global scale to say that just over half of healthcare facilities had a basic hygiene service, which is kind of shocking, you know, to think about half of healthcare facilities in the world where either the healthcare providers or the patients and their caregivers don't have even the means to wash their hands with water and soap or to use alcohol-based hand rub. Not to mention, you know, actual practice. That's a whole different thing. We're not even attempting to measure that one yet. One other difference between healthcare facilities and our work in schools and households is that the database is a lot thinner. So we're not yet actually confident enough in temporal trends to talk about, you know, how much things have changed either at the country or the regional levels. And that's because in many countries, there are just too few compatible data points. Hopefully in the future, we'll have trends. We also had enough data to make a global estimate on basic water services in healthcare facilities. And that really is a very basic level. That's just having water available from an improved source that's located on premises. Doesn't include water quality, doesn't include sufficiency or multiple points. Just, is there an improved water point on premises that actually has water? And, you know, that's an easier service level to reach. So we did find that 78% of healthcare facilities globally met that service level. Important regional differences with Eastern and Southeastern Asia being almost at 90% and Sub-Saharan Africa more around 50%. So I think this is probably one of the indicators that's the most recognized and most impactful when it comes to advocacy, because how can you deliver safe health services if you don't have water, sufficient clean water in a healthcare facility? It really resonates with the health sector as well as the wash sector. Now, the basic sanitation service indicator is a lot more complicated. I said it had 6 different measures in it. It's about having improved and usable sanitation facilities at the healthcare facility, but also making sure that different groups, different people within the healthcare facility can access and use sanitation facilities as they need. So that means having separate toilets for staff and patients, having sex-separated toilets that provide menstrual hygiene facilities, and at least having some toilet facilities that are accessible to people with limited mobility. And especially in the context of a healthcare setting, many people are there because they have infirmities. They might be permanent, they might be temporary, they might be elderly, they might be pregnant. They might need special adapted toilet facilities to be able to use them with dignity. And because there are so many elements in the sanitation service indicator, we don't have enough to make global estimates, not enough data. We did have 3 SDG regions. We had data from 41 countries in this last report, up from 27 2 years ago. So the data is growing. But what this chart here is, it shows all those different measures. And you can see that it's very common to have some kind of sanitation facility, even an improved sanitation facility. A little bit less of them are usable. But when you get into sex-separated, having menstrual hygiene facilities, accessible to people with limited mobility, the numbers just drop. So it makes it much harder to reach the basic sanitation service level, which is why you see much lower coverage figures than, for example, water for countries that do have data. So it's a tougher basic level than water is, or hygiene. Basic waste management services. This is another composite indicator. It's about having waste segregated at the point of generation and also treated and disposed of safely. Both sharps and infectious waste are considered. And again, we don't have enough data to make regional estimates, but it was interesting to show that if you plot these 2 elements, segregation and treatment, you know, it's just all over the place. So there are a lot of countries where there's really high segregation and really low treatment. And there are many countries where there's some treatment happening, but there's no segregation. And actually that one kind of makes sense if the treatment is, you know, throw it all in a pit and burn it, which is very common. It doesn't really make sense to segregate stuff if it's all going to go in the same pit and receive the same treatment. Now, open burning wouldn't count as an effective treatment for the basic service level, but in a lot of countries that don't have access to normative, high quality treatment, that is a better practice than not burning it, than just throwing it into the municipal waste, for instance. Then the last service level, the new kid on the block is environmental cleaning services. Again, not as readily collected, not as much data on this one. I think I should know, I think we had 27 countries. I'm not sure how many countries. Not enough for any regional estimates. But this is about having protocols in place and making sure that staff are trained in how to clean environmental surfaces. This came up because in consultations in the development of the framework, it kept coming up that people are not identified as responsible for training, for cleaning. When they are responsible, they're not valued, they're not given training, they're not giving materials. So we're trying to incentivize to fill that data gap. The number of data sources that we draw on for each report has grown. In our last report, we had over 500 national data sources. We are only using national data sources. And you can see that for water, for waste management, we have, 300, 350 like that. But for environmental cleaning, we just have about 50 data sources. Again, it's a new indicator. We do expect that will continue to grow as countries align with the global indicator framework. I want to quickly mention that all of the national data can be downloaded from our website. And we have what we call country files, Excel country files. If you would go to the healthcare website, you could make your own graphs, or you could download a country file. I'm just going to flash you the Uganda country file because it's a relatively data-rich country. Also, our country files can translate automatically into Spanish or French or Russian, so that's kind of fun. For the Spanish-speaking community in Uganda, now they can access JMP data. Excellent. But I wanted to show that we take all those national data sources and we put them in a very simple linear regression model. And that we do that because there might be different data sources that have different estimates even for the same year. And we don't say, well, this one is correct and that one's not correct. We just put them all in the model. Also, it allows us to generate estimates for all years. It actually allows us to generate trends, but we're not talking about the trends because in most countries, the situation is more like this, where there's like one data point and we'll extrapolate forward or backwards 4 years from that. It's rare to be like this, where you have a more or less continuous time series and you can actually have confidence in the trends. So actually, Uganda is interesting because it has both of those situations. There's a national panel survey every year showing a nice growth in basic water, but for urban and rural, and even for different types of healthcare facilities, there's less rich data. Now, this poses a particular problem because we have a lot of countries that have old data. So for instance, in Uganda, there was this ABCE survey in 2012 or so. We could use that to make estimates up till 2016, but after that, we're like insufficient data. So we use these country files to share the draft estimates with countries before we update the global database. So every 2 years, we have a country consultation. We send the draft estimates out to countries for review for a couple months, and we ask 3 questions. Are we missing any national sources of data? Are we using any that we shouldn't? Maybe it's not reliable, maybe it's not representative, or have we interpreted the data correctly? Sometimes, especially if the national indicators aren't aligned with the global ones, there can be translation challenges. If like a HMIS might say the facility has water or doesn't have water, and we want to know, well, does it have an improved water source that actually has water available? So sometimes there can be challenges in translation, and we ask for verification or assistance in that. We are just in the process of getting ready to launch our country consultation next month, in a couple of weeks. That'll run through about January. This is facilitated through the WHO offices and also the UNICEF offices. We send them the drafts. They convene national stakeholders to review them. And then we incorporate that feedback. But aging data is a big problem. And we can only make those regional and global estimates when we have enough countries that have data. And in China, they had a very nice survey in 2018 that's now too old to produce estimates for 2023. So unless we get new data from China, we're going to lose China, which means we'll lose probably our global estimates because our population coverage will go down. So the next report coming out next year might be thinner than the 2022 report. But I'm hopeful that through the country consultation in China, in India, and other large countries, we will be able to get enough data to continue and have some of those global estimates. So with that, I thank you, and I pass over to Josh. You're going next, right?
No comment from my side. Please record, write down your questions. So afterwards, during the discussion, we will have breakout tables and you could ask your questions directly at each table. So also for the people online, please, we have two people, John and Bruno online, who will also keep an eye on the chat and we'll have time to discuss with you the questions. Okay, thank you. Josh.
Hey, everybody. I'll let you know that I am new to the institutional WASH framework, but am trying to get booted up on it as quickly as possible. But most of my work previously has been in household settings and understanding water in those settings. But of course, there's issues, as Rick was saying, with water, sanitation, hygiene, well beyond the household. And we care about it for a lot of reasons. This is school setting, but also healthcare settings. We care about it because it affects things of public health importance, including school attendance and performance, risk of NCDs and hospital-acquired infections, patient and staff satisfaction, which determines how long people are going to work at a facility or if they even want to attend a facility to seek care, and also just dignity and safety of getting to use these facilities that are important for quality of life and well-being, and we all come into contact with these. So it's important that they meet these standards. And as Rick was saying, we have a data issue. We need these data to understand those outcomes and try to make progress towards achieving those health and well-being standards. And so Rick, as Rick was saying, I think this report is really nice. This was in the school report of households. We have pretty excellent data for national representation. Schools, middling, healthcare facilities typically at the bottom. So that's represented by the circles for a lot of these. And it's scary to hear that we're at risk of losing some more as well. And that also comes despite there being really useful guidelines. You can find a lot of great tools and guides for guidance on how to measure in these settings, including what JMP has put forward as recommended indicators or recommended items to make the indicators. And typically what we are measuring is what we can observe, what we can touch. That's really, it's not easy to do, but it is easier than maybe asking people about their satisfaction with services. It's we can go and observe it and count and touch and see whether the services exist and then the quality and functionality of those. I'll make a pitch that user experiences with these services also really matters. We know that well from the household literature. So in about 2018, 2019, we launched a tool for measuring experiential water insecurity at the household level. It complements the infrastructural data and the service availability data that JMP produces every year. And it helps provide a more nuanced understanding of, okay, somebody has a service, but is it meeting all of their household needs? Are they having to adapt or change how much they're drinking, for instance, or what they're cooking because there's intermittency, or they have to use multiple sources and we're only asking typically about one or two sources. So it's a 12-item scale. You can ask about it at the household or individual level, but we are finding really useful and interesting data from it. It's been included in the Gallup World Poll, so now we can start to get estimates of how many people are water insecure. This overlays nicely. I would love to see a graph someday of over the JMP data and how these look and compare and contrast. But you know, there's similar trends, but once you dig into the actual individual level data, you get some interesting trends. So now we can do, for instance, like sex disaggregated, gender disaggregated analyses to look at, for instance, are women or men experiencing more water insecurity issues. And it would be great to be able to do this for healthcare facilities as well. I'll say it's getting a lot of uptake because people are finding utility in experiences. These matter. Tons of organizations, and it's well beyond us who developed it, and it's great to see the public uptake. Experiences probably matter in healthcare facilities as well. This is a story from Brogan at Helvetas. who was talking about working with a community, and they were saying, yes, we have a piped water source and we would probably hit maybe some of the JMP criteria. It's really great, but it's not always there. So we also have this bucket of water that we will occasionally tap into, and then there's questions about how clean the cup is that they're using to transport the water, how often they're having to dip into this, if they feel like that's a dignified source, and if they like using water from this pipe source also. So to say, we have a data gap already, but I also think while we're thinking of how to scale up what to measure, thinking about maybe also measuring experiences could be really helpful, and just doing that from the beginning. We have a project trying to develop tools to measure experiences in WASH and also in healthcare facilities and also in schools. It's very early days. We presented this last year. We've made a little bit more progress since then, but we're still in the literature review phase and getting expert consultation and feedback on the tools that we've developed. They're very lengthy. Nobody wants to implement a 50 or 60 item tool, but that's how you start. And then you figure out what's redundant, what's not useful. And you do that through implementing at study sites. We have a few identified right now. For instance, like in Nepal, we should be hitting the ground in February to start doing this in schools and healthcare facilities. If you have interest and would like to participate in this project, we have all the tools developed and training manuals in development, so please reach out. We're looking for more sites to stress test these items, because then that will allow us to do things like me getting to play around on my computer and do fancy statistics and see what actually falls out as being the items to apply. Some reflections, but more than anything, I would say we want to get involved with this work. There's Sarah Young, John Brogan, and there's also, we're still open to expert feedback. So if you want to do this, you can see the tools that we've developed for schools, healthcare facilities, select to just do one or the other and go through and critique the items. Be mean, give honest feedback. That's what we need, because again, we have big dreams of applying this globally. So I'll turn it over to the next speaker. Thank you.
Good morning, good afternoon for those online. I'm Christina again. This is, go ahead, see you are real quick.
Yeah, maybe. Hi, everyone. This is Sudarshan, and we are here together to present this.
Great. And so we've heard kind of mention of the WashFit tool a bit. So we're going to talk about the kind of practical application of WashFit in two contexts, both from Helvetas in the Benin context and from TDH in Nepal. Oh, you're actually up first. Sorry.
Yeah, no problem. And as you can imagine, we're having a bit of a sort of a orchestration issue, but I think the purpose was to really get the message across, and we're representing the Swiss Water and Sanitation Consortium, which Terre, Helvetas, and there are 6 more Swiss organizations, which I'm not going to name it. But I think it's really important for you to know that this consortium started working in 2011, and over the years, and there are so many different innovatives and context, locally adaptable, context-driven approaches, flagship programs that have emerged within that project. And you can see in the picture, like we've covered already 50 healthcare facilities, 180 schools, and 240 communities. And in the 4th phase, which we've just started, we'll be covering the 12 countries, including Bangladesh as well. So the idea was that in the 4th phase, we'll be covering 170 healthcare facilities, 270 schools, and 226 communities. And as you can imagine, the numbers may not be that big, but the kind of evidences that it is generating locally is very powerful, and this has such magnificent impacts. And I'll be also talking through some examples from Nepal, and Christina will be sharing some successes from Benin case as well. So in terms of the 4th phase objectives, you can see that we really want to increase access and use of safe drinking water, sanitation and hygiene in all the settings. and as well as strengthen the capacity. And the term, if you like, is the system thinking that we are already familiarizing ourselves with, and more we are working with the local actors such as the local governments, municipalities, schools, and the communities to come together and work on it. And we want to make it a reality by working collaboratively with them, so that we don't actually work for them. It's like we work with them and then create that sort of mobilization. And definitely that we hope will contribute in the revitalization of some of the laws, if there are many changes to be made, or there are some adaptations were to happen, building on the evidences that we would have generated. So if you like, these are some of the sort of terminologies: advocacy, learning, innovation, and signature approaches. And many of these will build on what we have generated. So it will not be like a very brand new innovation thing, and we keep on innovating and not really replicating or taking it to the scale. Okay, with this, Christina.
Thanks. So just to start diving into kind of wash fit and what that means. So for those of you who aren't familiar, wash fit is the wash in health facility improvement tool. And it's a risk-based management tool. It covers 7 topics. Make sure I get them all here. So it's water, sanitation, hand hygiene, environmental cleaning, healthcare waste management, and then specifically looks at energy and building and facility management. And so, as Sudarshan was mentioning, as part of the Swiss Water and Sanitation Collaborative, this is a main tool that everybody is using within the consortium. So these are some experiences from 2 contexts of that. A little bit more on wash fit. It is this kind of 5-step cycle that does kind of come back on itself. That first step, which is forming the wash fit team, starts there. And the wash fit team is usually healthcare facility staff, management, and then also community leaders brought in to work on that. Everything from steps like 2 to 4 is very participatory, and again, cyclical as it moves along. Oftentimes these first few steps, as far as assessing, identifying, and prioritizing, can happen, fairly quickly over a few kind of very intense day workshops. But then as you develop and implement and review and monitor the projects, those are usually about monthly cycles. Again, depending on the project. Before kind of moving into a little bit more of the evaluations that have been done, just some kind of first thoughts on things that were immediate with implementing this as a pilot. So you can see kind of this, just some really low hanging fruit immediately coming up when you start using the wash fit tools. So things like team members just start talking to each other. Again, some really simple things, quality of care. People like are more qualified. You see kind of just simple things like waste bins and just some really low hanging fruit that you can really start working on very quickly with the wash fit tool. So as part of the Swiss Water and Sanitation Consortium, an external evaluation did come up from Oxfam. And so they're looking at 24 healthcare facilities across 3 of the contexts. So those are in Benin, Mali, and Nepal. And just a quick note that kind of our colleagues that were supposed to present these particular case studies couldn't come because of visa issues. So we're going to do the best we can to to be a substitute for these particular contexts. But just in general, this was done through a lot of key informant interviews with local government and health authorities, focus groups, and obviously observations from being in those healthcare facilities. So this is kind of the cycle that you'll see, the graph you'll see across the different countries. And you see those 5 different categories here. So water, sanitation, hygiene, waste management, and environmental cleaning. And this is specifically for the Benin work. So actually before this started, there was a lot of wash infrastructure that was just implemented in Benin. And so you see with this basic water it went from basically 0 to 100%. And that was frankly because of some chlorinated water that was put in and some water points right at the beginning of the project. So one of the kind of biggest outcomes of this really truly was basic level of services for water. There was no impact on sanitation and menstrual hygiene management, and that was mostly because of funding and not implementing those solutions during this phase. And then some varied results in kind of improvements in waste management and environmental cleaning. Again, one part of WashFit is this kind of cyclical process. So, you will be able to kind of track how these move over time. This study was just 2020 to an end line in 2023. And then just a few more thoughts beyond just kind of what we measure as it relates to the JMP. We are seeing just people saying it's just an improved cleanliness environment. These relations between the staff and the community are much improved. Just general community engagement is improved. And there's just a much better monitoring system. So this cyclical time to come together, review what's going on, in this very participatory way was seen as a big success of this program. And then just a quick note on kind of what the process is and where it's going next. There was a pilot in 2021, 2022 was really about this contextualization, additional training, moving to more facilities. And now in 2023, this is now being rolled out at many more departments across Benin. Over to Nepal.
Can I have a quick reality check? How much time have we got? Because that depends how much I'm going to elaborate. 2 minutes. Okay, I'll be really quick. So I'm glad that I don't need to explain them. And I think given the kind of people we have in the room, I think you'll be, able to understand what we're presenting here. So basically, as you can see in the baseline, it was in several areas of the WashFit, and it was in the areas where it had no service, at least by the end of the end line, it has progressed to the limited one. And the good thing was that wherever it had basic, was able to maintain it throughout. Those are the two important realizations. And definitely at least one cycle of WashFit was being implemented in all 5 steps annually. And one of the successes, and I must take a moment to explain this because we are privileged to have Dr. Sarvesh with us. He's the director. Please give him a wave. And because of his initiative and his team's support, we are now taking it back and outside of the Swiss Water Consortium to other provinces. And we're actually replicating and expanding the sort of study. And that was instrumental in developing the waste management strategy because, generating data is one thing, but what you do with the data is something that we need to always be mindful of. I think that was a successful example that came out of it. The other one was that, as you can see, all the figures have improved, and because of the timeline, I'm not going to explain in depth, but I think it's really important to understand that there was a very progressive realization and improvements, and that had also helped us, our team on the ground, together with our implementing partner, to generate awareness within the municipality, and therefore they were more willing to invest on WASH, and that had contributed in generating evidences. For example, in terms of like some of the areas where they were lagging behind, they were willing to invest more money. And then it was more like it continued on because every year they would need to put aside some resources. Anyway, that was not being used or utilized properly. Now that they had evidence that's in the data, they were more able to adequately resource some of these areas. So here is an example that was very, very a successful one. And again, in operations and maintenance, because oftentimes in the WASH sector, like it's more infrastructure driven, it's more visible, and what lacks behind in the developing countries context, at least in the countries or in the context where we operate, it's more on the operations and maintenance side where a lot of attention has to be driven. And that was where we were quite successful in showing them, walking them through by developing a sort of guideline and an SOP, so that it was very helpful. And even if there was a change of human resources within the setting, they were able to understand because they'd already agreed on a mechanism to follow through. That was quite a successful example one. I think the overall summary.
Yeah, Yeah, just really quickly, I know we're out of time here. I think just a few kind of thoughts that came out of overall, this tool was very successful and it's being used. It's again cyclical, so we're continuing to see improvements made in it. One of the things that we saw in the Benin context was adoption within the Ministry of Health. So actual funding being put into doing this more and being able to roll it out across more districts. And then in Nepal, as Sudarshan mentioned, the core motivating factors for healthcare facility staff were the steps themselves. So this process, the actual kind of scoring and making these improvement plans. So kind of the process being the most important part. We'll leave it there and say, thank you very much.
Thank you very much. And so we discussed first the data, now focusing more on implementation, right, to achieve the change. And now I'm going to go even a little bit more in detail on different types of interventions which we're developing or implementing within our project on the systemic approach to WASH in primary health facilities and also schools, but I'm not going to talk about schools. Specifically in this case in Mali and Burkina Faso. This is a part of the Hands for Health project, which is a big group of organizations here from academia, implementation side, and private sector, funded by Swiss Development Corporation. So what is specific about the Hands for Health project is that we focus on hand hygiene mostly, but also, of course, keeping as a part of the general WASH side with water quality and sanitation being also a big part of the interventions. We focus specifically on primary healthcare facilities. So it makes a big difference to the hospital. So we don't look in hospitals, it's really basic primary healthcare. Situations with basic limited or no water services, so no functional water supply system really in place in many situations. And we are working in conflict affected and vulnerable population setting. So before we go to kind of discuss about the systems and tools we implemented, I would like to show some insights in the review and compilation of existing tools, approaches, platforms, and networks, which were done within the framework of this project by Lindsay Denny from that time from the Emory University. And she looked into what already exists, because for us it was important, we don't need to reinvent the wheel, we need to build up on what is there and see where the gaps are, which we could try to cover with our project. So she identified 31 tools and existing tools and approaches which already exist WASH in healthcare facilities. So, and seeing kind of this big number, it was interesting to see, to structure those tools around specific topics of the phases of generally implementation of WASH interventions. And if you can see here on this table, we have tools which focus on general overarching framework, but then action plan and strategy, assessment. And if you just see on the all options which are there, you could see that assessment comes very strongly. So with a lot of different options there. So focus on collecting the data. So, but when we go already to management and enabling environment, it gets less options available, and on the level of insurance sustainability and continuation of services. So again, reducing the number of possibilities, and there are a few things in monitoring evaluation. Also, there's a couple of platforms and networks which are already there. So it's in principle 12 existing networks and platforms which are already available for WASH in healthcare facilities. So, and without going more in detail on that, because we don't have so much time, I would just like to focus specifically on gaps which were identified during this review study. And one is specific for emergency settings where we are working in. So there was clear a need to adjust the tools or kind of include, contextualize the assessments or interventions specifically for emergency context, because it was less available there. On the side of the hygiene promotion and behavior change tool, there was not so much available, and it was important also to contextualize the behavior change and hygiene promotion for the healthcare settings and for the emergency settings both, right? So, and on the side of evaluation was also clearly a gap. There's not really a clear evaluation tool which is available, which is could be used specifically on impact or health impact evaluation. So coming back to our project, to the Mali and Burkina Faso, so we looked at these gaps, and we specifically looked into interventions and tools which could be done. So we didn't develop, we tried with some innovation, but also focusing really on things which are there, and specifically focusing on affordable and quick win steps. So for management side and also for the behavior change. So conceptualize and adapting really to the specific context we have with primary healthcare facilities, with conflict settings, you know, and going more into the detail. Developing the methodology for evaluation of the impact and exploring underlying reasons why WASH systems are not in place and not functional. So just very shortly to see, like, this is the assessments which were done at the very beginning with the facility evaluation tools, so SDG indicators for Mali and 60 primary healthcare facilities and Burkina Faso and 101 primary healthcare facilities. You see where we are. So generally for the water supply, the situation was pretty good if you just consider the basic services. There's mostly boreholes, a pipe water supply in Mali, and boreholes available for a part of the healthcare facilities there. And I'm not going more into the other parameters, but specifically since our focus was on hand hygiene, would just like to go also a little bit more on hand hygiene. And the situation there was different, right? So we see there that the basic services only for a very small proportion of the facilities assessed. Interesting was also to see that basically 80% of the facilities had high hygiene coverage at the point of care level, but less than 20% had it at the level of the toilets, right? So we had there a big difference between where they are. And another interesting factor was from the baseline data collection is that in both in Mali and Burkina Faso, the reported behaviors were really high. So between 80 and 85% of the staff actually knew and told that they're doing the behavior, but on the level of the observed behavior, we are under 15%. So it makes a huge difference. And plus we found E. coli in many samples from the hands, basically on the hands of the people. So also the situation was with the hands, with hand washing, you can imagine. So that was the basically water tanks or buckets with the taps which people use for hand washing. So part of it was also sinks, but less. So the questions which were like, okay, why the situation is like this? What are the barriers? So we looked at use the theory of change-based mapping. So here also is a link. If you want to go more in details, you can just check the link for Burkina Faso. There is also one for Mali. After in discussion, you can ask me if you would like to take a look at that. So it's in French, so but you can translate with people. And basically, based on this assessment, we identified like 4 areas which we would like or we could cover, which is focusing on hardware, management, monitoring, behavior change. So prioritizing basically areas of action, but also defining the limitations, because there's certain areas you see there, it's all gray up there, something which could not cover for whatever reason. So it helps us to understand what we can and what we cannot do within the framework where we are. So, and of course, it's also a very useful tool to engage with stakeholders and get stakeholders on board from the very beginning of the work. So to see that we're working on this together, especially with the authorities in Mali and Burkina Faso, where they are really strongly involved in the work. So also understanding the kind of hardware part of the systems and limitations together with the teams using here the WASH fit approach, which is part of our tools, of course, because this is like you have seen from the experience is quite important, or a very important tool and used already at scale. So we focus specifically on kind of, this is just by example from the Burkina Faso, you know, we've seen like, for example, burden of carrying water was prioritized, water contamination, so which was not covered by the SDG indicator, right? Because it doesn't look in the quality of water in this case, management and maintenance of infrastructure, user behaviors, and so on. So for every facility, we have kind of a chart in this way to understand the situation. So what kind of tools, interventions did we come up with? Here we could see the hardware infrastructure part, the management and monitoring and behavior change. And very shortly, I will explain in detail what we talk about. So hardware rehabilitation improvement is basically hardware, like looking at hardware problems and trying to see what can be done with low resources available at the place. So which specifically focus for us on hand washing systems, increasing, improving storage capacity if possible, and potentially we discussing solarization of boreholes, but it's not, would not be part of that project, but a follow-up most probably in some cases. So we also looked in specific innovation, which is the hand washing systems which recycle water. So this is part of previous project also where our university and Gravitor Association were involved, which is basically systems which are built locally with using some of the materials from outside, imported from Germany, but most of it is built locally. So which allow to fill the systems once in a month, or once in 2 weeks to once in a month with water, and then using the foot pump to wash the hands, recycle the water, and kind of keep the water in the circle. So there's a treatment which removes the bacteria and viruses, but it still keeps kind of soap with it. So you have to replace the water once in a while, depending on how many people are using that. So since systems are produced locally, we could really adapt the designs also to the needs. And for the part of the project in schools, there's also kind of a version for the school there. Beyond that, we identified chlorination as one of the bigger problems as well for water quality. So we could develop kind of approach how to address that, not going too much into detail because we don't have so much time, unfortunately, but we can discuss in more details during our table discussion. So, and on the level of the management and kind of maintenance part, so one part, of course, is the wash fit, which is being implemented, or which this project is being implemented in the framework of, and using the wash fit as implementation tool. But we also specifically look in the circular wider approach to see if the preventative maintenance strategy could be developed and could be adapted for the healthcare settings. So there are advantages of that to kind of prevent the maintenance and repair and do the preventive maintenance before things get broken. So this is something which we're testing now, and of course there's a big discussion about the cost, like if it's sustainable, if the cost of the circular rider and having a person who goes and visits the facilities additionally would cover the savings you have from on leakages or on broken down infrastructure. So the part of the project was also developing of the Ranas model for the behavior change specifically for healthcare facilities, but Andrea is going to talk about it just after me, so I'm not going in detail. And we looked also in monitoring part, basically establishing the monitoring processes based on COBOL-based data collection linked to the dashboard, specifically also for chlorine, residual chlorine in the systems. So, but also generally for the activities which are being done and preventive maintenance activities. So having everything, all the data available on the dashboard, which for the ministries. So, and we hope in Mali and Burkina Faso, that's something we could get also further on because it's still also under development. So, and my last slide here is basically showing this approach of trying to integrate different tools in one practical and user-friendly tool, not reinventing the system. So we don't need to reinvent wash fit, it's already there. So we don't need to environment assessments, there is a lot there, but really trying to combine different tools. And during our discussion, so afterwards, it would be interesting to hear from you. What are the needs? Also, what are your experiences, and what kind of tools and information you would like to have in this tool if you would like to implement something like this in future. So thank you very much, and I give over to Andrea to talk more about Ranas specifically for healthcare facilities.
Okay, so I'm the last speaker and I'm standing between you and the group work. So bear with me. Who of you knows the Ranas approach to behavior change, or knows the model, has heard of the model? Not so many, okay. Well, we are using the Ranas model to develop behavior change campaigns for several behaviors around WASH, but also other behaviors. And in this project, we had the task to develop a behavior change campaign for healthcare facilities in the 2 countries for hand washing. So, well, you don't know, or many of you don't know the Ranas approach, but it's always a bit complicated because we always want to be evidence-based, data-driven. So we collect data, we develop the campaigns. So it's always kind of a process. And we also want to evaluate our interventions. So we try to break down a bit the whole approach and make it a bit more easier to be used by healthcare facility staff and, or say, let's train people who work with the healthcare facilities. So not start the whole process of developing the interventions each time anew. So we developed a toolkit within this project, which is a behavior specific, so hand washing in key situations in healthcare facilities, and context specific. So for the 2 countries. We've also done the same exercise for the schools within this project and also for separation of waste in healthcare facilities. But here I will only talk about the hand washing. So what does the toolkit actually comprise? So this is part of the Ranas approach. So we go from an explorative phase, we go to a quantitative baseline survey, then to analyze the data that we gathered, to developing the campaigns. And we put all these 4 steps that are necessary for each, for developing the campaigns. We try to make this a toolkit that can be used by a non-expert Ranas person, let's put it this way, and that are predefined. So I will go quickly to the 4 sub-tools that are the content of this toolkit. So the first one is, let's say, a bit trivial. It's a preconditions assessment, whether a behavior change campaign is actually appropriate. So we check on 3 main important indicators. That's behavioral, infrastructural, and organizational. So whether the organization is ready to engage, whether there's the necessary infrastructure, and whether there's actually a behavior gap. Then, so this is a tool. It's basically these 3 questions that you have to answer. Then a bit more of a tool is actually the quantitative baseline survey to collect the data. So we programmed this into Kobo. It's quite ready to use, and we measure behavior and we measure mindset. So if you don't know the Ranas model, we can go into that a bit in the group work if you want. But basically, we measure different psychological factors that we know can influence behavior. And we also know this is different depending on the specific healthcare facilities in a country, let's say. So this is different in different countries. So we say, okay, this data has to be collected. So we have this ready-made questionnaire. The next of the 4 tools, the third one, is an analyzer tool. This has been developed with in close cooperation with Terre in the 2 countries. And this analyzer tool looks at the differences between those who already do more hand washing than others. We have seen the self-reported and observed rates differed quite a lot, but we always have people who already do something better than others. And we look at those differences, and this is the basis for knowing which mindset factors, which behavioral factors are important. So for example, in this case, it came out that remembering is one of the important factors that makes a difference between those who do hand washing more frequently than others. So the last tool is maybe the most valuable and was also the most effort to develop, because to have this like an automated or a tool that can be used by someone not being a Ranas expert, we say, okay, we develop activities for each of the behavioral factors. So we came up with 15 activities that are ready-made to the context specific. They are in French for these 2 countries, of course. And then after the analysis, you only have to go to the catalog and select the appropriate activity. So in our healthcare facilities, we decided, okay, we do 3 activities for the 3 most important factors. And then you went to the catalog and selected the ready-made activities, and they look like this. So the catalog is illustrated with pictures. They have been pre-tested. They have been developed with the local teams. And now at the moment, they are being implemented and tested on a wider scale and will be evaluated next year within this project. So this is in a quick walk is the Ranas toolkit, Ranas for healthcare facilities toolkit. So that gives us an easier but still a structured and a data-based approach to develop behavior change interventions. As I said, everybody can use it after short training. So we're also testing on these kind of usability aspects within the testing. So I'm interested to get your opinions on this development of behavior change. So that's it. It was brief, as promised. Then,
So thank you very much. So now it's a very dangerous part because in many sessions, people stand up and go away as soon as someone says discussions. So we will happy to keep you inside the room still. We have about 25 minutes for discussion, and we would like to have like 10-minute discussion in a small group, and then you could choose and change the table so you can ask more questions and regarding different parts. So for the people online, if you're still there, there's a couple of participants there, so great, you are. There's also John and Bruno there who would be able to answer at least questions related to wash fit part and to their Hands for Health projects. And if there are more general questions, then please just write in the chat and we will try to feed those questions into the group discussions which is there. Yes, please. So yeah, exactly. What are the discussion questions? Maybe can you wait for a second?
Sure.
Yeah, just like 1 minute. Yes, yes. Sorry, I don't know what's happening. It's not happening. Yes, now you see the questions. Good. So we have 5 tables. So there are 5 topics here we are going to discuss. So first table is data to action GMP. So this is Rick. You can come to Rick, to that part of the room. Exactly. The second one is the experiential measures. So this is Josh, the top of Josh on the indicators in experiences. Sorry, insecurity indicators. So then we have a part with me focusing rather on scale up and the tools. So, and I will be just there very much at the back. So Christina and Sudarshan here at the front, please. Yes, on experience on implementing wash fit, and then Ranas in the middle. Okay, so please ask your questions, and during the group discussion, we will have also discussion questions to ask to you and get your experiences, which for us is really important also to get for further development of our tools and approaches. So please, let's go on. And we will come back at the very end for me, the main key messages. Yes, so we need to have 2 people get in on Zoom, get in the light.
Oh, okay. So I sent them a panelist thing earlier. I think they just declined. Bruno, Pascual, and John Brogan, right?
Correct.
Yep. So
Oh,
hopefully
there's
they
many
accept
people.
now.
There's not so many. Yeah.
Nope.
Okay.
There they
So
go.
they're living, so yes. Yeah. Okay.
Not a problem. And we're leaving this up. Sure. Okay. Do they need to see Bruno and John's video at all?
I don't.
Okay. Sweet. No problem.
Sort of intersection between multiple actors, right? The walk very, very all. And the way they're spending funds in education. How they're going to do outside of their comfort zone, maybe outside of their expenses around one area of education. First existed advocating for a model. Or whether it's Try to take on leading the sector, but I think there's a lot of resistance towards it. For invested time at these roundtables and nothing comes out of it, or they've seen an organization take the lion's share of that work. I mean, it's not to invest your time. Make them more comfortable in the sort of somehow voice they don't seem like because they're asking for so many things at once, they're trying to get the EFD. Years long process, trying to get the sale. That same kind of person with these larger donors, I think time effort convince donors to not take the sort of easy out and have impact numbers. The process and foundation. Financial support them all out there. I received it out. Having top line.
Change the table, but you don't have to, right? So we still have 10 minutes left. So you can take opportunity to change, or you can stay where you are and discuss. Yeah.
Yeah, I know. You have any like? In that, I think, for example, I'm just. We have to take some quarantine. I think that. I think basically, in India, earlier. And now we've got. You know, we did now. I didn't. Oh, yeah. Yeah, just in case you're interested in any of these, I have a few sort of handouts. I have found that interesting. Repeated, there's no one size fits all. Except on where. You're not extending that before. Why are we not willing to embrace that? Very delicate. They want to. So how do we open space? Kind of clear. Yeah, and this is like yeah, it's worried. Exactly, and that's where I think we're really focused on what our way to this management in many cases integrating we feel that we actually work on the jokes and the local
So we have 5 minutes left. And I would just like to use this 5 minutes, the remaining 5 minutes, to get the key messages from each table. So I'm going just to walk to each table and let the speakers just summarize the main points of your discussion. And since these guys are still discussing, I maybe start with them together first.
Getting more money.
Yes.
Are we still prepared or are we already? Maybe there's someone else. Okay.
So the table is not ready. So who wants to start? Who is ready? Who is ready to give the key messages for entire group? Because we still have 3 minutes to go. Josh?
Yeah.
Yes, perfect. So let's listen. You can continue discussion in a break, huh?
I mean, our key message is nothing shocking. It's just the difficulty of trying to measure anything in these facilities, of thinking about the different key players and movers. So patients, healthcare staff, and, you know, making bespoke scales for each of them if you're trying to capture their experiences. And you have to have a cutoff of length of stay at a facility. For patients are a really tricky group, I guess, of trying to capture them because they are necessarily, hopefully, moving through the system. Anyway, that was our reflection.
Great. Thank you very much. So giving over to Christina. Also, Darshan?
Yeah.
Go ahead.
Maybe I can. Two of the main important points was one around sustainability. How do we make sure that the healthcare workers get motivated and see the benefit out of it so that it doesn't look like an additional burden on them? The other piece around collaborations and also at times of changing funding landscape, how do we, as international and local NGOs working together, ensuring the system strengthening of the local governments and as well as the different tiers of the government. That's really essential for us to think about. Thank you.
Thank you very much, Rick.
Thanks. We had a fun conversation. We were discussing differences between GMP statistics and data and WashFit statistics and data, and their comparative advantages in different areas. And recognize that the WashFit collects the kind of granular information that you need to affect change at a facility level, whereas the JMP doesn't. So it's good for district or sub-district level work. However, sometimes the financial planning is not decentralized at that level and it has to come from a more centralized level. And there is scope, at least for GMP, to have more of a role at that high level strategic planning level. However, there is less engagement with between the JMP processes and national stakeholders. So there's a greater sense of ownership of the WashFit data because it's been collected by healthcare staff. It's been disseminated through some kind of workshop. People understand it better. Whereas the JMP stuff, it kind of comes down from Geneva and New York. There's nominally a country consultation process, but who's really involved with that? It's pretty thin. So it would be better if there was more engagement and dissemination of the JMP stuff with national level stakeholders. And there are some examples of where more intensive things have happened, like in Uganda, UNICEF worked on a costing tool to, at the national level, calculate and at lower levels, how much it would cost to reach the basic service levels. So that, and that involved a lot more engagement with the national stakeholders. So that might be a good example of how JMP data could be more useful at the national level through a more engaged process with national stakeholders. Fair? Have I got it?
Right. Thank you very much. And Andrea and Darcy?
Yeah, well, we talked about, and my takeaways from this discussion are that we should look in terms of behavior a bit more into the differences between hand sanitizer use and water and soap, which wasn't possible in this project due to like the low data base on that. That in some of the activities that we developed, we could also include elements of competitions. There was an example on the table that I found really interesting. Also, I think you mentioned that some allocation of funds are associated with who has the best services or the best hygiene behaviors in a healthcare facilities. I thought this was really interesting. Then also, one other person mentioned that we should include doctors and into the whole activities, not only with nurses and other health personnel, but from the top of the healthcare facilities, include the management. And it's really important to have them on board. And also in terms of infrastructure, there's oftentimes there are gaps that actually have to be fulfilled from that side before we can do meaningful behavior change campaigning. And that it's not only the existence of, let's say, hand washing facilities, but also where they are located and so on. Yeah, these are my takeaways. Anyone wants to complement?
Okay, great. So my group was the last one here. So we discussed about the scale up and specifically focusing like what are the factors which influence in the possibility for scale up of interventions which work, or maybe what are the barriers when it doesn't actually happen. So, and some of the topics we discussed was that actually working with authorities, of course, is key, but the advocacy has to start from the very beginning, and it's often a matter of time. So like all our experiences were that it takes really years to have a really kind of good cooperation and engagement with the authorities. So, and in this case, it means that this time has to be there. So short-term programs are actually not helpful for that. So it was kind of message also for the donors to see that this focus is not just should be of the projects on kind of very easy ways of getting the impact there, but actually have really long-term programs which support in development and establishment of this these relationships with the local authorities. We also discussed of the role of the large international organizations and how like the smaller NGOs sometimes struggle to have there, like to see the smaller NGOs might be those who have more flexibility, innovation and so on, but not being part of this larger group. So there is definitely needs for better coordination between these different groups of kind of sectors. Yeah, and I think basically I think that was it, I think, for us. The last point, which I'm still missing, it's the ethics, right? So very often also the discussion between the work, the collaborations, the coordination is based on ethics. And that's something which is no one talks much about. So, and it's maybe a topic which we have to look more into the detail. Yes, so thank you very much for your attention. I think it was a great session. It was really nice to see that I could not stop you continue discussing. So please continue in the break. And I would like also to pay your attention that one topic we didn't discuss in our session was costing. So there will be a group on costing at 1:30 in Dogwood, I think. So specifically on costing on wash in healthcare facilities. So please come and let's continue the discussion. Thank you very much.
Same sort of meaning, community management. That's sort of the parallel. But it doesn't work out. Everybody is ready to offer us on the system. But we are seeing right now. So we recognize, right? Second line, right water has low rates. When you
oh no, I
exactly. The community knows where every client is. They know that's another thing the contract don't. This is something we need to learn down that increasing from Latin America, providing tech support, increasing a little bit out of
Oh, yeah, that's a awesome one. Yeah, how